Association of Community Cancer Centers. I want to thank you all for joining us in today's webinar, The Deal with Data, Collecting and Sharing, as part of the Molecular Testing Peer-to-Peer webinar series. Funding and support for this series is provided by Pfizer Oncology. This webinar will be presented by Dr. Joe Kim and will feature Dr. Pablo Gutman. Dr. Gutman is the Department Chair for Pathology at Holy Cross Germantown Hospital and the Medical Director of the Cancer Institute at Holy Cross Health. He has been a leader in process improvement initiatives for molecular testing at his center. Dr. Kim is the President of Medical Communications Media. A couple of reminders for today's webinar. If you look at your screen, you're going to notice there is a questions text box located on the lower right portion. This is where you can ask the presenter questions throughout the presentation. Just simply type your question in the box and hit send. We are going to collect the questions, and Dr. Kim and Dr. Gutman will answer them during the Q&A portion at the end of the program. Please also note there will be an email sent to all registrants within the next few business days advising where to access the archive for this webinar, as well as a link to the slide deck. At this time, I'd like to turn the session over to Dr. Kim.
Great, thanks very much, and it's a pleasure to be here. We're excited to share with you some information from projects that we've done on the topic of biomarker testing, molecular testing in non-small cell lung cancer. And one of those projects really involves us actually going out to different ACCC members and conducting learning labs. But before we get started, let me ask Dr. Gutman to just introduce yourself, tell us a little bit about your hospital and the cancer program and the volume of patients that you all see there.
Yes, sure, Joe. So thanks for having me here in the first place. And I'm the director of the cancer program at Holy Cross Health, which is a two-hospital system outside of Washington, D.C., about 600 beds between the two hospitals. And for now, approximately 2 years, thanks to our participation in a quality improvement initiative sponsored by ACCC and Pfizer, we have managed to get to almost 100% of testing of our non-small cell, non-squamous cell carcinomas of the lung. Before this initiative, I think we were pretty typical for a community hospital or community hospitals our size, and we were not very efficient at doing this. And again, in the last 2 years, we have made tremendous improvements, and hopefully we'll discuss what those improvements were.
Great. Thank you very much, Dr. Gutman. So the ACCC's 2014 project, titled Molecular Testing in the Community Oncology Setting, was a continuation of some work that had been going on for the last several years. And this was a project where we actually went out into the community. We went to 8 different cancer programs, and we had each of these centers actually evaluate their own biomarker testing processes and then held these interdisciplinary workshops with the entire care team. Every center reviewed their own biomarker testing for advanced non-small cell lung cancer. And then the learning lab itself was 2 hours of us actually presenting their own information, discussing their workflow processes, and then actually identifying key opportunities for change and improvement that would ultimately yield better outcomes and higher molecular testing rates. Each program also identified 2 to 3 specific process improvement ideas and employed the Plan, Do, Study, Act, or PDSA cycle for improvement, and tracked those improvements and then provided follow-up information after 3 months. So here on this slide, you'll see that these were the 8 ACCC member programs that we went out to. These programs are all around the country, and they also vary quite a bit in terms of size and in terms of patient volume. Here you'll see that with the 8 different centers, we've actually de-identified these 8 programs, and we've clustered them into programs that treat over 100 lung cancer patients, as well as those who treat less than 100 lung cancer patients. EGFR and ALK testing rates for the larger programs averaged around 60%, with some all the way up into the mid-70%. And those on the smaller side were lower. On average, they were between 47 to 52% for EGFR and ALK testing. And so once again, when we went to each of these programs and showed them their own data and actually discussed their processes, we challenged the team and asked them, why are the testing rates what they are? and where do you hope to take them in the future? So the objectives today are that we are going to review some of the key insights from these programs that we conducted over the last few years. And we certainly know that in today's environment, we are living in an era where biomarker testing is really becoming mainstream. Precision medicine, personalized medicine, more and more patients are becoming aware of these terms. And we also know that there are still key opportunities to make improvements. So for instance, around the whole reporting process and working with electronic health records, every organization is in a different place along that journey. There's also the opportunity to use digital communication to share information more effectively. And when it comes to health IT, there are some centers who will say that health IT has really been an enabler for them, and it's really improved their clinical workflow processes. And others that will admit that health IT has actually been more of a barrier and a hindrance. So we'll talk about that. When it comes to some of the health IT resources that some of the larger centers have access to, we know that, for instance, big data analytics and clinical decision support can come as a real resource to help those clinicians and to guide them in clinical decision making, but not every organization has access to that, and we're certainly hearing more projects and initiatives that are really being spearheaded by groups like ASCO and other organizations evaluating how this can improve patient care. And there's also this ongoing need to perform a cost analysis, to evaluate the value, and even to look at things like the new ASCO framework, the value framework in oncology and cancer care. Where do these different pieces all fit in? So we know that non-small cell lung cancer is a heterogeneous disease, and there are a number of different driver mutations that have been identified over the years. Back in 1987, the medical community was aware of the KRAS mutation, but they also knew that there were a slew of other mutations that just had not been identified yet for non-small cell lung cancer. Fast forward to 2004, and at that point we know of KRAS, we also know of EGFR, and then come 2013, now that there are a number of mutations that have been identified, there's still a significant number that have not been identified, and we know they exist. And we also know that these driver mutations can be targeted with certain therapies. So there are currently some FDA-approved therapies, and then there are also a number of therapies that are under investigation. And the NCCN continues to encourage clinicians to identify patients who have these driver mutations so that they can either be targeted or they can enroll in clinical studies. Now, in 2013, the College of American Pathologists, CAP, the International Association for the Study of Lung Cancer, IASLC, and the Association for Molecular Pathology, AMP, released guidelines titled Molecular Testing for the Selection of Lung Cancer Patients for EGFR and ALK tyrosine kinase inhibitors, or TKIs. And that guideline really provided the framework for some of the key discussion points we'll get into in a moment. But we know that earlier this year, in January, CAP, IASLC, and AMP announced their plans to update these guidelines because so much has changed in this molecular testing arena. And specifically in this press release that came out in January, they specifically mentioned things like ALK testing recommendations, as well as EGFR and ALK resistance, the role of emerging molecular targets, and the need to rebiopsy and repeat analysis when patients relapse with progressive disease. So going to those 2013 guidelines, which once again provided the framework of discussion during our learning labs, if we go to section 1, question number 2, a critical question is when should a patient specimen be tested for EGFR and ALK mutation? And you'll see here that the recommendation and suggestion specific to EGFR and ALK testing comes specific to advanced stage disease or stage 4 patients with advanced non-small cell lung cancer, and that you'll also see that on the bottom, tissue should be prioritized for EGFR and ALK testing. And the reason that that is specified is that there are some centers and oncologists who may really insist on sending that specimen out to various labs or perhaps to different places where you may be testing for multiple different mutations. But if there's not enough tissue, the recommendation here is to prioritize specifically, start with these 2 known mutations, and then go from there. Now, we know that although the recommendations are to test tissue, there are a lot of different barriers that prevent this from happening 100% of the time. And even if it happens, there are still barriers when it comes to accessing the information, communicating those critical results to decision makers like the medical oncologists, and really being able to access this information electronically so that the entire team can work in a cohesive sort of team-based approach. So some examples here include, the medical oncologists may not know if molecular testing is being ordered when they originally see the path report on a patient who is newly diagnosed with lung cancer. The path report may say adenocarcinoma, and it may make no mention of whether or not that specimen was adequate or if it's even been sent out for biomarker testing. So we talked about this during the learning labs and encouraged centers to see how can they improve that communication, whether it's written, whether it's verbal, whether it's electronic. There's also inconsistent documentation by different pathologists across different health systems and hospitals when it comes to adding those molecular test results to the original path report that didn't have that information. So once again, we had some opportunities for discussion on how should these pathology reports document this information, and how should that information also get communicated to medical oncologists. The lack of interoperability across different IT systems was a common theme that came up over and over, especially because in many instances the hospital might use one EHR, the outpatient medical oncologist may use a different system altogether, and then the pathologist might be on a different platform as well. So there's still, even in 2014, 2015, a lot of printing, scanning, uploading of documents. Much of that data is unstructured data. It's not searchable, and it just becomes really problematic and inefficient when medical oncologists are looking for this information. Sometimes they have a hard time finding it, even if the data or the results are there. So we had some discussions around how can that be improved. And there are often no electronic alerts notifying medical oncologists when those biomarker test results actually come back for their patients. So some places have been dealing with this issue of alert fatigue and looking for ways of just sort of balancing those notifications in terms of the type of notification and the frequency, and trying to customize and tailor it based on the needs of their clinicians and getting that kind of feedback. So I want to pause here and ask Dr. Gutman for your feedback. I know that these are some key barriers that we've identified as we went out to different programs around the country. But at your organization, when it comes to some of these issues such as standardized reporting and electronic communication, did your organization deal with these similar kinds of issues and barriers? And if so, can you tell us about them?
Yes. So there's two aspects to this. There's one aspect is what is required by the College of American Pathologists, and that is that any type of ancillary or additional testing associated with the diagnosis, with the pathology report, be attached somehow to that pathology report. To my understanding of what the College of American Pathologists is requiring is that we do not separate the diagnosis of a non-small cell carcinoma or of an adenocarcinoma from the molecular testing that is coming back. And to assure that, what we have decided to do at our institution is to add the molecular report to the original pathology diagnosis in the form of an addendum or a supplemental report, whatever one wants to call it. That is, that to comply with what the College of American Pathologists is asking, we consider the pathology report, the diagnosis, and the molecular testing all one. But the second aspect of this is that practicing in a community setting where we are among many other community hospitals and many academic centers as well, it is not uncommon at all that our patients get their diagnosis here at this hospital, but then go and ask for an opinion at an academic center, or are referred by their pulmonologist or a thoracic surgeon to an oncologist that does not practice at our hospital, and then even further yet to a radiation oncologist that may not practice at our hospital. So if we separated somehow the pathology report, the diagnosis, from the molecular testing, it is very likely that someone practicing at another institution that does not have access to our computer system would never be able to either know or obtain the molecular report. So again, to assure that those things are together, we made a very specific, conscientious decision to keep those two together. The other thing that we did is we made a decision to test all new diagnosis of non-small cell non-squamous cell carcinoma. And the reason for that was, again, that at the time of the diagnosis, pathologists are not aware of the stage. Many times the thoracic surgeon or the pulmonologist is not aware of the stage of the patient. And waiting to find out the stage could mean several weeks of delay until the molecular tests are ordered. In addition to that, at the time that a pathologist is making a diagnosis, they don't know who the oncologist will be or who the radiation therapist will be. So to wait until an oncologist is on board would mean, again, further delay. So in our institution, again, the decision was the diagnosis and the molecular component of the testing stay together, and the molecular testing is done on all non-small cell non-squamous cell carcinoma.
Great. Thank you, Dr. Gutman. And we'll certainly be coming back and readdressing some of those key issues that you've brought up, especially as it relates to interoperability and data sharing. We know that within the pathology community, the College of American Pathologists, or CAP, has actually released a number of different templates. And when we went out and conducted these learning labs and asked the pathologists in the room as well as the medical oncologists in the room, are your pathology reports following these templates? Would you like them to or not like them to? There was a lot of different opinions and discussions around the utility of following these templates based on, once again, what their electronic record system could do. Some of these templates include a lot of checkboxes and lines and fields, and some of these electronic systems were very adaptable, and so you could actually incorporate these fields and modify them at any time. So once again, we bring this up as one example because there were several programs where the pathologist said, yeah, I think actually modifying and following some of these suggestions that CAP has released and modifying our existing template would be of benefit. It would clearly communicate to the medical oncologists. In other cases where we had these discussions, the medical oncologist didn't necessarily want to have so many fields. So I think that the key takeaway here is keeping in mind the culture of your organization, the needs of your clinicians, as well as trying to establish consensus on what they think is going to be most beneficial, as well as what they need to do in order to comply with all the various requirements to create a system so that the key pieces of information are being exchanged across the different specialties, but also being exchanged in a way that's clinically meaningful and beneficial. This is just one section of that template. And once again, it's not the entire template, but it just shows you, for instance, the different ways that pathologists might be documenting a biopsy, and especially as it relates to things like adequacy, as well as whether or not EGFR mutation has been performed. One of the drawbacks and limitations of possibly using a template like this might be that, down the road, you may want to, within your own program, employ the use of different biomarkers. So right now, EGFR and ALK are sort of standard, but then down the road, if there are additional biomarkers that you start adding to this, you just need to make sure that your templates are adaptable in that way. Another example that came up was really around the use of health IT, because this, once again, in today's era, was both an opportunity as well as a key barrier. And when it came to interoperability solutions, there were a lot of different ideas that came about. In some cases, some hospitals were in the process of upgrading their electronic record systems, or even planning on switching within the next year to a whole different platform. So there were discussions around either middleware solutions or some hybrid approach where they could try to really minimize the amount of printing and scanning that was currently going on, but they all also admitted that that was sort of commonplace, that a lot of results continue to come in via fax machines, and then they have to print and scan those reports and upload them. So there was a lot of manual processes that, once again, we explored ways to see, could this be automated? And then We also talked about things such as, informing the medical oncologists that, hey, this information is now available. Perhaps you now want to, based on this new information, schedule an appointment for that patient to return so that you can either modify treatments or start something new. There were discussions around data analytics and clinical decision support, but for most of these, at least smaller community-based hospitals, they really didn't have a wealth of large resources around things related to big data analysis. But they also agreed that it's going to be interesting in the future to tap into some of those things. And many of them were excited to see where some of these initiatives, for instance, the ASCO Cancer Link and other programs, what that will look like in the future, as well as how that might influence their decision-making patterns. Dr. Gutman, as it relates to things such as interoperability, you had mentioned that some patients come in from different centers. They may go elsewhere for second opinions. How, in your area there in Maryland, how are those records currently being exchanged? Is it really the patient getting hard copies and paper and then going from center to center? Or do you know of any other sort of electronic exchanges that currently exist that facilitate this transmission of patient records in your area?
No, there is no electronic transmission once a patient goes outside our system. Now, within our system, the doctors that are credentialed to practice here in their offices, of course, they do have access to our computer system, so they can see what we have within Holy Cross Health. But again, if the patient goes and sees an oncologist that is not credentialed at our hospital, that oncologist will have no access to our medical records. So for the most part, when our patients go for a second opinion, let's say to an academic center, they will either carry with them the slides and the report, or we will forward the slides and the report to that center. But no, there is no interoperability electronically with hospitals or doctors outside our system.
And how about as it relates to within just your department, the pathology department, of different records coming in, whether they're, the biomarker test results, how much of that is being transmitted electronically and then uploaded electronically into the patient records as opposed to, coming in through fax machine, being scanned?
Sure. That's a very good question, because the reference lab that we use for this testing has the ability to direct the results right into our computer system. But we opted not to do that again, because in that case, we would have a report in our computer system that would be separated, that would be dissociated from the pathology report. So what we have opted to do, this is somewhat primitive, let's say, but effective, is that since we have access to our reference laboratory computer system, there's a cut and paste going on. Basically, our transcriptionists see the report in their reference lab, they select the report, they copy it, and then they paste it into our pathology report. So it's not the same as scanning, and scanning has its difficulty, especially with these difficult type of reports where scanning sometimes does not interpret some of the symbols correctly. So at least this is purely electronic, but there's still a manual component to it, which is that copying and pasting. That's how we've solved that problem of putting the report, the molecular report, into our pathology report.
Okay, and then how about as it relates to clinical alerts? When the report and the results come in, is there a process to alert that oncologist that this new result is there, or do the medical oncologists get something that pops up on their screen when they log in?
No, because, I should say most of the times no, because, again, who orders the biopsy? It's, for the most part, probably a thoracic surgeon or a pulmonologist, sometimes someone from internal medicine, a hospitalist. So at the time that the report goes out, the only physician's name associated with the case is that thoracic surgeon or that pulmonologist, etc. So when we put in that supplemental report, that addendum, the only person that is informed that there is a new result, and our computer system does alert the ordering physician that something was added to a test, the only person would be the ordering physician. So again, at the time the molecular testing comes back, there may not even be an oncologist associated with the case at that point. So The short answer to that is no, not necessarily will an oncologist be alerted that the molecular report came in, and that's more so if the oncologist does not even practice within our system. That there would be no way to get that report to that oncologist.
Sure, and I know that, you know, once again, going back to the learning labs, these 8 programs, you know, it was different at every cancer program, because in some cases there may have been, you know, 1 or 2 predominant medical oncology groups. In other places it may have been 3 or 4 medical oncology groups, and even some solo medical oncologists. And so communicating that across, you know, the team, as well as seeing whether or not they're all on the same platform. Many of them, in some cases, were using different electronic health records. So these are all, I guess, issues and barriers that we face today. And when it comes to communication and alerts and notifications, I know that there are some programs that are even just using, you know, for instance, mobile secure texting and having more communication that way, so that, you know, they'll actually send a message that's encrypted, that's secure, notifying that clinician that, hey, so, you know, make sure you check this updated report on patient XYZ, because this just came in, you know, today. So these are all things I think that are sort of ongoing. But returning once again to the learning labs and those 8 programs that participated in this initiative, I think one of the key takeaways that we heard over and over again was that this one project that really did focus on non-small cell lung cancer allowed the entire team to embrace this change, this culture change towards continuous quality improvement. I think there are often in many of these hospitals, you know, nurses and others trained in patient safety and quality improvement, and they perhaps have formal training in things like the process improvement methodologies. But we also found that many other clinicians, such as pulmonologists, surgeons, radiologists, and even medical oncologists and pathologists, they didn't necessarily have the formal training in quality and process improvement. So it provided sort of that framework to introduce them to this opportunity, to teach them that this is not just something that you just change once and then you're done, but rather it's got to be this cycle of ongoing improvement and ongoing auditing and feedback and communication and teamwork. And so there were several organizations that actually, as feedback to us, said, you know, based on these learning labs and these meetings, we're actually going to start organizing either a monthly or quarterly internal meeting, and we're going to review X, Y, and Z within our organization. So we were really pleased to hear those kinds of feedback. It certainly also allowed the organizations to sort of reevaluate who do they want to have formally trained and educated in some of these process improvement methodologies, whether that's in better use of these Plan, Do, Study, Act cycles, or even in some of the Lean and Six Sigma methodologies that originated originally from the manufacturing industries. So it gave us a lot of opportunities for some discussion around those things. And then several programs also said to us, well, this was a great start in lung cancer. It's also allowed us as a team, when we've come together and hold these discussions, to have honest feedback around, you know, opportunities for improvement in other tumor types and in other disease areas outside of lung cancer. So it was great to hear that, for instance, some of them wanted to explore ways of improving and reducing some waste in some other treatment areas, for instance, breast cancer or colon cancer, prostate cancer, and so forth. Now, the Cancer Quality Improvement Program is something that was started in 2013 by the COC, the Commission on Cancer. Every program that we went out to for these learning labs was accredited by the COC at some level. And in 2013, the COC just started with this first annual report that just provided some very basic data, such as demographics, some basic quality metrics, survival, and so on. Then the COC said that in 2014, they were going to launch this Cancer Quality Improvement Program that would include 12 quality measures with comparative data across different types of COC programs. So programs of similar type would all be compared across other programs of similar type. So the NCI designated centers would be compared with other NCI, and the comprehensive community cancer centers would be compared against other comprehensive cancer, and so forth. Now, the 2014 said that they were going to start with breast, colon, non-small cell lung, prostate, and melanoma, but they also made mention that as every subsequent year, they're going to really expand on these reports and use this kind of quality measure and comparative data to see how cancer care is being, how cancer is being managed in the United States. So I think for all of us, we have to sort of think about how are we evaluating our own performance in our programs and our cancer centers. What kind of reports do we have access to? How are we communicating that information to our teams of clinicians? And how are they coming up with improvement plans so that we can actually make those improvements? I think unless you're very deliberate and you structure and plan and organize those kinds of processes and meetings and workshops and identify key opportunities, you know, the metrics and this data, especially in this world of transparency and value-based cancer, is just going to become available, and it's going to influence patients and family members who are making clinical decisions and choosing where they're going to receive their care. So as we think about the future of lung cancer, we know that this future of biomarker-driven medicine and clinical trials is continuing to grow, especially with the President's announcement around this precision medicine initiative and specifically calling out, you know, cancer treatments. I think more and more patients are hearing about this. We also know that lung cancer screening is growing, and we're seeing more programs either starting to launch their lung cancer screening programs or grow them and promote them and market them to primary care providers in the community, as well as directly to patients. And these guidelines around biomarker testing continue to evolve. I'm sure that we're going to hear more about this later on this year as well as next year. And we are living in an era where reimbursement models are focusing on much greater accountability and value. So I think as we think about where we are going in health IT, as well as the growth of things such as the big data analytics, there are clearly opportunities to make improvements, but there are also some basic things that can be done within each of our programs. And I want to just remind everyone on the call today that if you all have questions, please make sure that you type them into the question box. We are starting to get a few questions here, so I will address them to Dr. Gutman in just a moment. I will also remind you that there are some really important resources that are available on the ACCC website under Provider Resources, including information around these learning labs, as well as some recent publications around biomarker testing. So with that, as we get ready to sort of start diving into some questions, one of the questions that's come up here, Dr. Gutman, is just around this whole big data analytics, clinical decision support. Where do you see that going as it relates to community centers, and what's happening specifically in your program as it relates to these kinds of technologies? Can you elaborate on some of those things?
Yes, well, I'm not an IT person, so I can't comment in detail about those kind of things. But clearly, as you mentioned, we are being evaluated, community hospitals, academic centers, etc., on our outcomes, the quality of our care, and our reimbursement is very likely going to be based on that. So the quality of the data that we collect will have an impact on our reimbursement. Now, how does that translate specifically to molecular testing? I'm not exactly sure. But it brings up a good point, and that is, for example, if we are putting the results of our molecular testing in our pathology report, and that is not being captured in a way that someone coding for a case or someone who would be capturing all this information in some kind of more analytical, generalized way, they're not able to capture it that way, then we have a problem. Then we're going to have to reevaluate what we're doing and say, well, maybe now we need to work with registry, and registry will have to be tracking whether molecular testing was done or not. Or we will have to go back to a system where the reference laboratory result goes in as a separate item because that can be captured by the people coding these cases. And again, we'll have to rethink this. But at this point, that's not where we're at. We are, at least at the community level in my hospital, is taking care of individual patients and making sure that the individual patient has their molecular testing done in a timely fashion. And I think that's very, very important because as we know, the survival of patients with advanced lung cancer is measured in months, and the delay in 3 weeks to a month in obtaining a test can be quite significant from a clinical perspective.
Sure, no, absolutely critical. Another question came in here regarding just lung cancer screening programs. Can you tell us at your center whether or not lung cancer screening has been in place for a while and what has changed in terms of like the volume of biopsies and what you're seeing as a pathologist as it relates to lung cancer screening?
Yeah, so in our cancer center, we've been fortunate enough to be part of ILCAP now for over 10 years. So we've had extensive experience in a research protocol in lung cancer screening. We've over the last 10 or 11 years, we've seen about 10 to 12 cases of lung cancers with screening after testing over 1,500 patients approximately. So the question for us now is how do we translate what is being done at a national or international level in a research-driven into a model that will fit more a reimbursement type process, since this is now approved by Medicare. And that is not that simple. Translating what we've been doing, again, from a research perspective into an everyday screening, non-research type setting is more challenging. And the challenge, I think, is really making those primary care providers aware that this exists in the first place. Most primary care providers are not aware that they can screen a certain population of their patients that fit the criteria for screening. And I believe that over the next few years, as they do become aware of this, we will see a significant increase in screening, and we're preparing for that.
Sure. No, thank you for sharing that. Another question that came in is just regarding the EGFR versus ALK. How did you establish consensus amongst your oncologists on which biomarkers that you would test sort of reflexively when patients have known adenocarcinoma of the lung? Can you explain how you came up with that in your program?
Sure. So I think in that regard, the CCC and the project that we participated with you a couple of years ago now was very helpful in getting the different stakeholders, the thoracic surgeons, the radiologists that do their CT-guided procedures, the pulmonologists, some internal medicine people, some oncologists, radiation therapists, etc. We were able to all get in a room, and everyone basically was able to explain their expectations. Of course, in an ideal world, we would only be testing the stage 4 patients, and we would be doing it at 100% efficiency. But from a practical perspective, I've already explained why most of the times we don't know the stage of the patient, we don't know the oncologist who will see the patient. So the decision was made as a group that a more effective way of doing things was to test 100% of non-small cell, non-squamous cell carcinomas at the time of diagnosis, and that would assure at least that we would not miss any stage 4s, although we are testing patients that, according to guidelines at least at this point, may not need to be testing. Having said that, many oncologists will say that they do appreciate having a baseline because, as we know, many of these patients will be stage 4 at some point. So I think this idea of getting the stakeholders, getting the different doctors, the different specialties in a room, and over a certain amount of time, that can't be very long because you can't have people in a room for many, many meetings lasting many, many hours, but I would say over 2 to 3 one-hour meetings, we came up with this, what we thought was the more effective way of doing things.
Great. And we have time for one last question, which is really just around clinical trials. Can you explain to us in your setting, in the community setting, how are patients identified and recruited for clinical trials, and is that either increasing or decreasing, especially as it relates to lung cancer?
So, I'm not sure if we are the typical community hospital in that regard, because we sit about 3-4 miles away from the NCI. The people from NCI come and participate in our thoracic tumor boards. So we do have a significant number of patients that go to clinical trials, both pharmaceutical type trials, NCI type trials, and of course having the ability to place a phone call and have a patient maybe travel a few miles to a place like NCI is extremely beneficial. So I don't know if we are typical again, but we have a substantial number of our advanced lung cancer patients participate in clinical trials. And I believe that that should be the overall trend. As we know, there are significant limitations and significant difficulties with outcomes with these patients. So once they have gone through therapy and they do not respond, I think it's the belief of most oncologists that those patients should be moved to clinical trials. And that ties in a bit with the question that you asked me before, is what happens with the tissue and how much tissue do we have? And as we know, we've discussed this extensively in the past, but we're aiming for this primary testing for EGFR. And as we all know, then 3 weeks later, or a month later, or 2 months later, come in the requests for maybe Foundation 1 testing. And at that point, of course, from a core biopsy or a navigational bronchoscopy specimen or an EBUS, the amount of tissue is very limited. So that second-tier testing that is being requested from us, at least at the community level, is becoming a significant issue.
I see. Yeah, and it sounds like, I mean, that's certainly going to, continue to evolve. I'm sure a lot of people envy your geographic location being so close to the NCI as well as a number of these major academic centers. Well, we've run out of time. I want to thank Dr. Gutman again for joining us. I want to remind all of you on the line that on the ACCC's website, under Provider Resources, you will actually see the ongoing advances and improvements in molecular testing. That's there as a resource, as well as it's actually going to be mailed out with the July-August oncology issues. And so at this point, I want to hand it back off to Daryl to just wrap up with logistics.
Thank you very much, Dr. Kim, and thank you, Dr. Gutman, for speaking today on the webinar. And we want to thank all of you out there for participating.